Okay, it's 2:03. We have a huge number of participants. Again, welcome everyone. On behalf of me, I'm Vince Faustina, Michelle Loy, Alison Nair, and Phil Spinella. We'd like to welcome you to the first webinar sponsored by Palisi and BloodNet. This is going to be a very interesting set of talks. We're going to talk about coagulation testing for the pediatric intensivist. I do not think it means what you think it means. Michelle, can you move on to the next slide, please? So we have 4 learning objectives today. First is to identify coagulation tests used in the care of critically ill children. Second is to learn how the hemostatic assays are performed and how the tests relate biologically to coagulation. Third is to learn clinical applications of different tests. And fourth is to discuss advantages and pitfalls of tests as they relate to pediatric critical care. Next slide, please. So before we start with the first talk, I'd like to remind everyone, if you have questions, and I know you're going to have questions, please type them in the chat box. We have allotted a large amount of time towards the end of this webinar so that we can answer all of them. Again, type them in the chat box. We're going to complete all the sessions and then discuss all the concerns that you have regarding coagulation testing at the end of the webinar. Also, we would like to request you to submit your feedback regarding the webinar. Michelle's going to show a QR code at the end of the webinar. We would like to know how this went on. We would like both positive and negative feedback so that we can do better the next time. Okay, so this is our overview for today. I'm not going to go each one of them, but we have 4 very good talks and then a Q&A at the end. This will go on for the next 2 hours. So for our first speaker, we have a rising star in acute care hematology. She's double boarded in pediatric hematology oncology and pediatric critical care, and she is an assistant professor for both divisions at the University of Colorado, Children's Hospital of Colorado. For our first speaker, we have Michelle Loy. Michelle, the floor is yours.
Michelle, you're muted.
Michelle, you're muted, yep.
Hi, guys. Thanks, Vince. So for the next 5 or so minutes, I'll attempt to give a general overview of coagulation. I feel like my hematology mentors will consider this blasphemous because how can coagulation biology be covered in 5 minutes? But here we go. So as a general guide, these are some principles I've come to understand about coagulation. So number 1, hemostasis is a dynamic process moderated by both anticoagulation and procoagulation proteins, often working at the same time. Number 2, the coagulation cascade explains abnormalities in testing, but doesn't always translate to biology. And number 3, to quote the words of Alsma, you have to admit that hematology can be hard. It remains a challenge even for the hematologist, and that's what's so fascinating about it. So another wondrous thing about coagulation is that despite the complexity of hemostasis and all the factors that have to function correctly, most of us walk around without bleeding or clotting at any given time. And it takes constant balance to achieve that. So this is a scene from a Marvel Avengers movie, Endgame, if you're wondering. And although it depicts a battle between good and evil, let's just imagine that it's a sized up battle between proteins that cause coagulation and proteins that break clots down, and they're showing down at the endothelium. So as far as their powers are matched, we maintain hemostasis, but if something is offset, such as if you have additional inflammation or a piece of plastic bumping up against the endothelium in the form of a central venous catheter, one side may become more powerful and a clot may form. And we'll go into 2 available models of coagulation next. So the classic coagulation cascade will help interpretation of your classic coagulation tests. The intrinsic and extrinsic pathways are not terribly intuitively named in the first place, and so in the simplified diagram, they've been replaced by the name of the test they represent. So in the intrinsic pathway, now called the PTT pathway, abnormalities in the proteins of the PTT pathway will cause prolongation of your PTT. The same goes for your extrinsic or PT pathway. They meet at X. X marks the spot, or factor 10, which with factor 5 as a cofactor starts the common pathway, which eventually leads to the development of a mature cross-linked fibrin clot. And there's going to be more details in the next presentation. In the second and maybe more sophisticated model, Maureen Hoffman and her group developed the cell-based conceptual model of coagulation. So there are two main concepts to this model. Firstly, there are three distinct and overlapping steps in clot formation. And secondly, spatial proximity matters. So two cells, a tissue factor bearing cell and a platelet, have to be brought together in close space in order for the clot to progress. So in initiation, tissue factor is exposed, and this tissue factor, factor 7 activated complex, activates small amounts of factor 9, 10, and thrombin. These proteins continue being produced in small amounts in this stage. In the next stage, amplification can only really occur when this damage to the vasculature allows platelets to spill out or percolate into the extravascular tissue and adhere to this tissue factor cell at the site of injury. Then you have on Willebrand's factor 8 that also spill out, and then factors 5, 8, and 11 are then activated at the platelet surface. And then through this positive feedback loop, more thrombin is activated, and then the platelets aggregate further. In the third step, propagation, aggregation of these activated platelets and the further generation of these previously activated factors results in a massive thrombin burst. And these activated platelets are also linked by fibrin. And then a clot is formed. So this slide will provide a visual explanation to the physiologic formation of a thrombus. So every year in an event titled the Mountain of Hell, 700 bikers hurtled themselves down a 2,500 meter glacier in the French Alps. And this video from 2019 exemplifies a lot of the concepts of thrombosis. So in this, the glacier route represents a vessel, the terrain is the endothelium, and the bikers are all coagulation proteins and platelets and cells involved in hemostasis. So these components of hemostasis are happily and smoothly moving along a vessel, and they make it past this vessel narrowing, as you see here. There's some rough terrain or endothelial damage, and it's really at this point of collision that the first step of initiation is achieved. This causes the activation of other platelets and coagulation proteins, and the process reaches amplification. You can even see this small burst to the right. And then the process propagates. And eventually, even further downstream, a clot is formed. And you can see even as the thrombus is forming, you can see some clot breakdown and fibrinolysis occurring as the bikers get up to continue their route further down the glacier. The original video to this is actually 4 minutes long, so you can imagine the magnitude of this clot. And so with that end, I wanted to thank you all for joining the webinar today, and I will hand the microphone back to Vince.
Michelle, thank you very much for that great introduction. I know that coagulation can be held, but I never thought of it as a Mountain of Hell bike race. So it's a pretty great way of looking at it. So before we move on for the next talk, I'd like to remind everyone to please turn off your video and mute yourselves. Please enter questions in the chat box. We have a good amount of time at the end of the webinar. We're going to go over all the questions that you have. But as they come along, as questions come up in your head, type them in, and we're going to answer them later. Okay, for our next speaker, he's a professor of pediatrics at the section of Division of Pediatric Hematology, Oncology, and Bone Marrow Transplant at the University of Southern California Children's Hospital of Los Angeles. He's also the director of their hemostasis and thrombosis program. But probably more importantly, as you guys are doing your shopping, he's the author of a suspense and mystery hematologically inclined novel.
Painful plug.
Blood. So Guy, I'm doing the plugging for you. So our next speaker is Dr. Guy Young.
All right, well, thank you, Vince, for that introduction. And I wasn't expecting a plug on my book, but yeah, if you need a Christmas gift, it's a medical mystery involving bleeding and coagulation. So you might enjoy it. And I have to applaud Michelle, because I think that was about the most creative way I've ever seen anybody talk about how a blood clot can form where there's bad blood flow, but it was actually, I mean, I think the analogy worked perfectly well. So that was brilliant, actually. That was really, when I first saw that, I was like, where is this going? But it was very well done. So kudos to you, Michelle.
Thanks, Greg.
So I'm gonna, there'll be a little bit of repetition here when it comes to the coagulation cascade, but I think repetition when it comes to the coagulation system is not a bad thing. It took me about 150 times to review it before I actually even understood the first part. So just briefly, normal coagulation, the classical coagulation cascade, because again, Michelle did a very nice introduction there, so I'm not gonna sort of belabor the point. And then we'll get into really the main part of mine, which is about laboratory tests. And specifically, I'm just gonna focus on the PT, the APTT or PTT, factor levels, and specifically fibrinogen, including fibrinogen. And then just briefly at the end, a little bit about fibrin degradation products, fibrin split products, whichever way you prefer to call it, and D-dimer. So yeah, normal coagulation, you know, this is the physiologic system, the way that I kind of describe it. And as I think one important thing to understand is that it does start with factor 7 and tissue factor at the rupture of the endothelium. That's the normal way things progress. And then you generate just a small amount of thrombin by doing this part of it. Then that thrombin acts as a feedback to generate, to activate the essentially lighter fluid of the coagulation cascade, the catalysts, factor 8 and factor 5. Factor 7A also activates factor 9 to 9A. And then 9A plus 8A generates a lot of factor 10A. And then 10A plus 5A generates a lot of prothrombin, which gives you this thrombin burst, which is what's needed to actually stop you from bleeding. And then the fibrinogen gets, of course, converted to fibrin, which is the clot-forming material. Factor 13 comes into the fold actually as well, activated by thrombin. But the important thing is factor 13 cross-links fibrin. This is not required for the way that the PT, PTT, and factor assays are done. So you do not need factor 13 to make a normal PT and PTT. You do need factor 13 to make a good, healthy clot. And factor 13 deficiency, albeit rare, is a very serious bleeding disorder. But with respect to the coagulation tests, that is not a component that is required for a normal PT and PTT. So just the first part of fibrin is what is formed, those first non-cross-linked fibrin strands is what makes enough of a clot to stop the PT and PTT assays or to complete those assays. And then factor 11, I'm sorry, that's a little off there. I think some of this happens when I switch from Safari to Chrome, but factor 11 comes in, is only necessary really later on. Sorry, it's only necessary for very significant amounts of thrombin because it enhances factor 9A generation. And that's why factor 11 deficiency, for example, those patients don't bleed unless they have trauma or surgery. Another way to look at it, Michelle kind of went through this, just a different way of looking at the cell-based model. You have this initiation phase where you generate a small amount of thrombin, again, via tissue factor, factor 7A pathway. Then that activates on the surface of platelets, it activates factor 8, which then with factor 9, and then also activates factor 5. And you get the propagation phase where you generate a lot of thrombin. It's just another way of looking at what I just showed you. Now, the classical coagulation cascade, which is what Michelle went through with respect to the tests, you've got the intrinsic system, which is composed of prekallikrein, high molecular weight kininogen, and factor 12. Those are the three contact activation factors. Now, these are important when it comes to catheter-related thrombosis because catheters act as a surface, and they're called contact activation because on the contact with an artificial surface, be it a glass test tube or be it a surface of a catheter, this system does get activated. So this is important, and there are in fact anticoagulants being developed that are inhibiting this aspect of the system, particularly factor 11 and even factor 12 that are in development that may be particularly more useful for an ICU setting where contact activation is important because of the catheter situation. But otherwise, the classic coagulation cascade is kind of what Michelle showed you. This is what she called the PTT pathway. I like that name better too. And into the common pathway. And then making fibrin, and there's factor 13. And then you've got the PT pathway here. I'll show it separately in a second. The big difference is that in this pathway, factor 7A is not linked with factor 9. But in reality, factor 7A does activate factor 9 to 9A. So that's a big part of the difference between those two. You know, why is this one important? Well, this one's important because of the laboratory testing. And we'll talk more about that. Michelle briefly touched upon that. So let's get into the nitty-gritty now of lab testing. The first part we're going to talk about.
Your slides have stopped advancing.
They have stopped. I hate when that happens. Okay, let me stop share. You know what? I may have to go back to Safari. I mentioned that it's happened to me a couple times.
Yeah, that's okay. Let's just, we can try again. Yeah, you have time.
Can you see it or no?
Not yet.
No, okay. I'm going to have to, oh my gosh, I'm so sorry about that. You know what? I'm probably going to go back to Safari. See, I knew it wasn't necessarily a Chrome issue.
All right.
So just give me, if everybody just give me a couple seconds, I'll be right back. I apologize for that. And I don't know, I have to figure out why this keeps happening. I will be right back in just a second.
Okay, hang tight, everybody.
Sorry, can you all see me or no?
I can see it.
All right, and then can you see the slides?
Yes.
All right, I apologize for that. This is a diagnostic problem that I'm having that is not a medical diagnostic problem. But I've had this happen once or twice before. Okay, so hopefully it won't happen again. What we're going to talk about first is really something important, which is about how you procure the sample and the processing and handling, because this really can have a major impact on the test results. So the sample procurement, so venipuncture is always the preferred route. Now I know in the ICU, patients have central venous catheters, and you often rely upon that to draw blood. And that's okay, but there are some limitations, and we'll get to that in a moment. So venipuncture, again, venipuncture is always going to be the preferred route. And for coagulation testing, we use sodium citrate tubes, blue top tubes. So why do we use these tubes? Citrate chelates calcium. Without calcium being available, the coagulation cascade can't proceed, and therefore the blood will stay in its sort of anticoagulated form, if you will, because the clotting system will not start once the blood touches the citrate. There is a small amount of citrate below. Notice the size of the tubes, right? 1.8, 2.7, 4.5. Why is that? Why are they multiples of 9? They're multiples of 9 because the citrate to the blood to citrate ratio for these tests to be done accurately must be 9 to 1. So the 1.8 sodium citrate tube has 0.2 mLs of citrate, and the 2.7 of course has 0.3 ml, and 4.5 has 0.5. So if you're wondering why the tubes are that size, they are that size. And then we'll talk about the filling in a moment. So what are some of the sample procurement problems? So if the blood is not a free-flowing blood sample, we know in kids especially sometimes, or in older individuals where you're not getting a good vein, or the veins aren't good, you're kind of pulling the blood out slowly. Keep in mind, remember the contact activation system? That blood is touching plastic tubing, and it's going to start getting activated. If the blood is flowing slowly into the tube, you're already activating your coagulation system, and you're consuming your clotting factors. So you can end up with a falsely elevated PT or PTT. Samples from heparinized line or a formerly heparinized line. So lines that, maybe where you ran heparin through there, maybe now you're not running heparin through anymore, you're running saline, but the heparin really sticks to tubing. So even if a line is not actively running some heparin in it, if it had been running heparin, that can cause a problem. The amount of blood in the tube is crucial. I'll point that out in a second. So here we focus in on the tubes a little bit more. And what you'll notice is that these tubes, unlike most other blood tubes, they have a line. There's this little blue line right there, and that's the fill line. And you do need to fill the blood right up to that line. You don't want to overfill, you don't want to underfill. That doesn't have to be like 100% exact, but I mean, it can't be, 10, 20% below, and you don't want it overfilled either. A proper coagulation lab, if they get a tube that's underfilled, typically it's more underfilling, right? You don't get enough blood. They should reject it because you're going to get false results, which is not helpful to you. And so don't get upset with the lab if they reject a sample because it wasn't filled properly. Now, most of you are working in institutions where you're going to have extremely well-trained nurses and phlebotomists, and this really shouldn't be an issue. It does, though, come up as an issue sometimes with outside labs. I saw a quick question on the value of larger tubes. There really isn't a value with the larger tube. It depends on how many tests you're drawing. So for example, for me, I take care of bleeding disorder patients. So I see somebody come in with, epistaxis and heavy menstrual bleeding, and I might need to do a bunch of factor levels plus the PTT plus von Willebrand factor. So that's going to take more blood. And so we may use 1 or 2 larger tubes instead of multiple smaller tubes. So it really depends on just how many tests you're doing. If you're just running a PT, PTT, anti-10A fibrinogen, one tube, one 1.8 ml tube should be plenty. Your hospital may not carry them. They're a little bit harder to find. But if you're working in a NICU or a pediatric ICU where you've got smaller patients, you should ask your hospital to stock those tubes. Can I comment on the microtainers? So I don't know that there are microtainers for blue top tubes, and even so, those are really, those can be a little bit more problematic. You don't get a lot of volume. If you do have blue top microtainers, I mean, if you get enough sample, then that's fine. Again, if you have to do the proper fill though. Okay, so pre-analysis specimen handling. Now, this typically is not a problem for you guys. You guys are ICU docs or hematologists, you're working in a hospital, but keep in mind, if you have a patient that, was in another hospital and got transferred to you, I mean, these still could be issues. So just be aware that the samples, when they're drawn, they need to be kept cold until they're processed because the clotting factors start to break down fairly quickly. Ideally, the plasma should be separated and frozen, if not analyzed immediately. So if it's coming from another hospital or from an outside lab, keep in mind that you may get false samples. Now, I realize that for this particular audience, it's not so much of an issue, but if you are seeing, patients in a clinic or outpatient setting, for those of you who may do that, and you're getting a sample from, Joe's lab next to the 7-Eleven, that, this may be a problem where the sample just sat there all day until the courier came and then he brought it to the lab and then it sat in the area where they receive, the receiving area. So keep that in mind that really these should be kept cold. Ideally, if they're not analyzed immediately, that's the ideal. Analyze them. When I say immediately, I mean within about an hour. Then oftentimes it's good to just separate the plasma and then freeze them. And this is really the most common reason for in an outpatient setting for an abnormal PT-PTT. I can't tell. I mean, literally every clinic I have, which is 2 days a week, 1.5 days a week, we get patients who are referred for prolonged PT-PTT, and then we do the labs in our hospital. We get authorization to do the labs in our place, and they come back normal. This happens, I mean, literally 2 to 3 patients every single week. Again, you're working in an ICU. This shouldn't be an issue for you. What happens next? What happens next is that sample gets centrifuged, and you separate the plasma from the red blood cells. The neutrophils will be with the red blood cells, and then in the middle is what's called the Buffy coat, which has the mononuclear cells, lymphocytes, monocytes, and platelets. And again, the ratio of citrate to plasma is critical to obtaining the proper results. Now, as you look at that tube on the right there that's separated, if the amount of citrate to plasma is too high, then the result will give you a falsely elevated PT or PTT. And I'm going to give you a patient example of something that you probably have seen at some point in your career that can lead to a problem. We'll get to that soon. Okay, so let's talk about the PT and the PTT. How are these actually done? So, I, as hematologists, sometimes like to call it the APTT, although everybody calls it the PTT for short. A, because it's activated. There was a test called the PTT years ago. I mean, like 40, 50 years ago. So it's really the activated, and that's because we use activators to accelerate the process. So here's a tube of plasma. I put in all the contact factors, high molecular weight kininogen, prekallikrein, and then the intrinsic factor 12, 11, 9, and 8. And then you see the common pathway factor 10, 5, 2, and fibrinogen. And so I bolded the activator. So the activator is important, and that's why it's called the activated partial thromboplastocyte. You need to have phospholipids because remember I showed you earlier that this whole reaction of clotting happens on the surface of platelets. That's how our body works. And so we have to put, and platelets, basically their membrane flips from the inside goes to the outside, and which has a very strong amount of phospholipid, which facilitates the coagulation reaction. So you have to put artificial phospholipids in there for the reaction to happen, has to happen on the surface of those. And there's lots of different phospholipids. It's not that important which phospholipids are used, but the activators can make a difference, and I'll talk about that soon. And then, of course, calcium. So remember, we use citrate to chelate the calcium, so the reaction doesn't happen until we want it to. And therefore, once you have your sample and you add the activator and phospholipids, the last step that happens inside the machine is calcium gets added because, of course, you need the calcium, so you have to recalcify the sample. And that's what the activators are. Those are the PTT reagents. It then goes into a coagulometer. This is one example, is the coagulometer we use called the ACL Top. There are several different coagulometers on the market. They all are very expensive and really generally very good machines. The PT is a bit different. We mentioned the extrinsic and common pathway. Here you're adding tissue factor. You still need phospholipids and calcium, but we're adding actually artificial tissue factor. This often is in the form of, believe it or not, rabbit brain, which is a common source of tissue factor. There are artificial sources of tissue factor, including recombinant human tissue factor. So the tissue factor is not so crucial what is used there. There aren't too many options there. And then, of course, that goes into the coagulometer and it'll run the test for you. Just to give you an idea, though, this is just from a paper about the number of different reagents available. So there's no need to read this. I actually put this unreadable figure or table just to point out how many PTT reagents are. So that's the column. All of those are PTT reagents that are available. They may not all be available in the United States, but most of them are. So there's well over 20. And you see there's a variety of different manufacturers. And so this does matter. And it matters because some PTT reagents are more sensitive to a deficiency of factors, and others are more sensitive to a lupus anticoagulant situation. So it depends on what your hospital is looking for and what your coagulation lab prefers. Some big coag labs will have two reagents, one that is good for factor deficiencies and one that is good for lupus anticoagulant. And in your ordering system, they sometimes may ask you, are you looking for a factor deficiency or are you looking for lupus anticoagulant? And this way they can choose the reagent. The activators are basically some sort of contact. Remember, the PTT is a surface. It needs to touch a surface. So the activators can be made of silica, basically like little sand particles, kaolin, which is essentially like clay, ellagic acid, which is just an artificial contact, and polyphenolic acid, which is another one. I think, depending on how interested you are in this or how involved, you might want to know, what instrument is your lab using and which PTT reagent is your lab using. And then you can look up to see if it's sensitive more to factor deficiencies or lupus anticoagulants. This is from an abstract a few years ago, just to show you, what is used in the United States mostly. You can see that, silica is overwhelmingly the most common one. There are two different platforms, two different manufacturers, but you see about 60% of the labs in the US, at least when this was done a couple of years ago, use silica, and about another 20% use ellagic acid. Not too many use kaolin. Okay, so why does this matter? As I mentioned, some PTT reagents are more sensitive to factor deficiencies. Some are more sensitive for lupus anticoagulants. You actually can't have it both ways. If you have a PTT reagent that's more sensitive to factor deficiencies, it will be less sensitive to lupus anticoagulants. And that has to do with the activators and the phospholipids that are used. So, being aware which reagent your institution uses may help you determine the sensitivity of what you're looking for. So if you suspect a patient has mild liver disease and they may have a factor deficiency or they're bleeding, and your institution is using a PTT reagent that's not that sensitive for that, or not as sensitive, I should say, you may get a normal PTT where your neighbor or one of your colleagues here in their lab for the same sample may get an abnormal PTT. So keep that in mind. These are subtle things, but they can make a difference clinically. So you may want to get a sense of what your hospital is using to make those kind of decisions. So this whole thing is about, what are these lab tests and what are they not? So what really are the PT and PTT? I mean, what are they? These are basically screening tests that were developed back in the 50s. They were developed when people were discovering the clotting factors. So they're screening tests for most factor deficiencies, for factor levels, for most factors. I mentioned they don't screen for factor 13 deficiency. That's, again, it's rare, and you're going to ask a hematologist to help you with that anyway. So I don't think that's a big issue for intensivists to think about. But keep in mind, they're screening tests for factor deficiencies. If a factor level is sufficiently low, I put in quotations because it varies for the different ones, you can get an abnormal PT or PTT or both. They can be used with some limitations, though, to assess the level of anticoagulation. Of course, for heparin, people can use the PTT, although the anti-10A is much better. You're going to get a lot more of this in the next talk, so I'm not going to spend a lot of time on anticoagulation management, but just keep in mind that the PTT is often used for argatroban and bivalirudin, but you'll hear more about that in the next talk. Now, what are these not? And this is particularly somewhat for the intensivist, but also for surgeons when you're working with them. These are not tests meant to predict bleeding. This is the biggest misconception of these tests, that these are tests that can help you predict if a patient is going to bleed. That is wrong. That is false. Let me give you 2 examples why that is false. So deficiencies of the contact activating proteins, high molecular kininogen, prekallikrein, factor 12, are going to give you a very abnormal PTT, 100, 120, 130, beyond the upper limit of normal. Yet these patients have no bleeding disorder at all. I had a patient once, about 10 years ago now, who needed surgery. They did a PT-PTT. It's not really necessary to do that. That's a whole nother discussion. But suffice it to say, it came back greater than 150 seconds. They sent her to me. We did an evaluation. She had a factor 12 level of 0. She had no factor 12. But she was 13 at the time. Never had any bleeding, and she shouldn't have any bleeding. Factor 12 deficiency is not a bleeding disorder. I sent the surgeon a note saying, patient is cleared for surgery. Don't worry about the PTT. I explained why. He refused to do the surgery. I mean, ultimately, she had to find a different surgeon who would actually trust me because he said, no, the PTT predicts bleeding. I'm not going to do it. So again, this is a good example where the PTT is not predicting bleeding. Factor 12 deficiency patients, very abnormal PTT, no bleeding. The opposite is the patients with lupus anticoagulants. With a strong lupus anticoagulant, you'll get a prolonged PTT, sometimes a prolonged PT. And we know that for the most part, these patients don't have a risk for bleeding. In fact, they are at high risk for thrombosis, some of them who have the antiphospholipid syndrome. So that's a good example. Now, just to say, some patients with lupus anticoagulants have something called the lupus anticoagulant hypoprothrombinema syndrome. So they have low factor 2 and they can bleed. But in general, that's really rare. In general, these patients are actually at risk for clotting, even though their PTT is prolonged. So those are 2 examples of clinical scenarios where these tests are not telling you at all about whether somebody's at risk for bleeding. They are telling you, though, if a patient has a factor deficiency. With respect to the lupus anticoagulant, that's more of an interference because of the phospholipid in the assay. People with lupus anticoagulants have substances that interfere with those phospholipids, and that's why you get a prolonged PTT. So there are limitations for these as preoperative tests. Again, I went through this already, but PTA, PTT, if you're really worried about screening for factor deficiencies, but factor 12 deficiency patients, I already mentioned, don't bleed with a prolonged PTT, and factor 13 is a severe bleeding disorder with a normal PT and PTT. They're subject to many false positives. We already discussed that. And they can be truly abnormal, aside from factor deficiencies, yet still not suggest an increased risk for bleeding, lupus anticoagulant. So again, Michelle showed you this, calling it the PTT pathway and the PT pathway. I like those names better, actually, too. And so this is kind of where the things break down in terms of the PTT, the intrinsic pathway and the common pathway, the PT, the extrinsic and the common pathway. And so the deficiencies, I'll skip this just to get to this figure. So if you're worried about somebody with bleeding, if they have a normal PT and a normal PTT, and they have a bleeding issue, they still can have factor 13 deficiency. If they have a normal PT and a normal PTT and a prolonged PT, now you've really isolated it down to factor 7 deficiency. And factor 7 deficiency doesn't mean congenital. It could be acquired from liver disease or vitamin K deficiency. If the PTT is prolonged, but the PT is normal, then you're in the intrinsic pathway where you'd have deficiencies of those substances, of those factors, or you could have a circulating anticoagulant, like I said, a lupus anticoagulant, or it could be from heparin. And if they're both prolonged, well, it's a lot of different things, as you can see in that box with liver disease and vitamin K deficiency, et cetera. Mixing studies, this is an important way of isolating why somebody might have a prolonged PTT. You could do a mixing study if it corrects. That means there's a factor deficiency. It means the normal plasma corrected the deficiency in the patient's plasma that led to the prolonged PTT. If it doesn't correct, it means there's something in the patient's plasma that is inhibiting the PTT from being normal, which often would be a lupus anticoagulant and less likely a specific factor deficiency, specific factor inhibitor, excuse me. All right, let's talk about a couple of cases, some troubleshooting. So here's a case, and this is a made up case, but I mean, I've definitely had cases like this. So a 4-year-old, congenital heart disease, didn't really get repaired. He has Eisenmenger syndrome. And the whole point here is that he needs a surgical procedure and he's got a high hematocrit. His hematocrit is 65. His PT comes back normal, but his PTT is prolonged. Now this patient, she's had multiple.
Guy, I think your presentation is frozen again.
Oh, no.
It was pretty fast the first time. Do you want to try again?
Yeah, I guess I will get out again. And so I'm really sorry about that. I don't know why this keeps happening. I'll be right back.
Okay.
So we're already seeing a couple of questions coming in. Feel free to type them in. We have sufficient time at the end of the talks to go over all of the questions.
Got it.
Okay. All right. Can you see that again?
Yes.
All right. Okay. So again, back to this case, essentially, again, patient with a high hematocrit, and the PTT is abnormal. And now she's had multiple procedures before when she was younger, including open heart surgery, and never had bleeding. So your history is really important. This patient doesn't have a history of bleeding in spite of being challenged. So you don't suspect a bleeding disorder, but the surgeon is demanding a normal PTT before proceeding with the surgery. And believe me, I know that that happens quite a bit. So let's talk about artifacts in the coagulation test. I also threw in the thrombin time here, which I'm not really going to talk about very much, but it's a similar test to the PT. PTT essentially just looking for fibrinogen issues. So again, I mentioned the sample, I mentioned earlier, the sample relies on that proper ratio of plasma to citrate. If there's too little plasma, essentially, it could be due to a tube that's not properly filled. But again, that shouldn't happen in your institutions. But the other way you can have too little plasma, in other words, the plasma to citrate ratio is not 9:1, but maybe it's 4:1 or 3:1. The other way is a patient with polycythemia. So imagine this patient who has this patient is 4. They should have a hematocrit of 35. So you can think of it as a plasma crit, right, or plasma concentration of 65% of their blood. But theirs is actually reversed. They only have 35% plasma because I already told you the hematocrit's 65. So you've got half as much plasma as you're supposed to have. Your plasma to citrate ratio is now off. It should be 9:1. In this example, it could be, for example, 4:1 or 4.5:1. And so in this case, you can get a falsely elevated PTT through no fault of the blood draw, right? This is not what we call pre-analytic problem. It's not the blood draw. It's not the underfilling of the tube. This is just, there's nothing you can really do about the fact that the patient has polycythemia, and that's the result you get. So important for you to be aware of that. Well, what's the solution? I mean, Dr. Young, I can't fix the patient's hematocrit. What can I do? Well, you can talk to your lab. The lab can provide you with a special, essentially a homemade tube. They'll just grab a regular plastic tube, and they will look up the CBC. They'll look up the plasmacrit, if you will, right? So the opposite of hematocrit. Plasmacrit's not a real word, by the way, so don't use that. That's why it's in the quotations. And they'll set it up so that you can have a plasma to citrate ratio is 9:1. So if the plasmacrit is half what they expect, or if the hematocrit, I should say, is double what you expect, they'll just put half as much citrate in the tube. And they'll tell you, they'll send the tube up and they'll say, you need to put 3 ml in here, or you need to put 4 ml in here. They'll give you instructions. And then you run that sample, and then you get a normal PTT. The patient can have their procedure. Here's another case, 8-year-old with Down syndrome, in mid-ICU for severe pneumonia, pleural effusion. You guys put a femoral catheter. He's sick. He's got a high white count. The rest of his CBC is normal. Then his condition worsens. He has an empyema. He's not responding to antibiotics, and you want to do a VATS procedure. And so you do coagulation testing from the femoral catheter, and you get a normal PT, but a very prolonged PTT. So you say, oh, yeah, well, there's heparin in the line. So let's repeat the sample. Let's take off a 10 cc discard. That's our ICU's protocol. That should take care of the heparin. And it comes back, it's a little better, but it's still 74. And now the surgeon is angry with you because now it's really late in the day. So what should you do? Well, a venipuncture is performed, but it's performed with difficulty. And the sample demonstrates a PTT of 63, right? It was really hard. The nurse did her best. They were pushing and pulling and finally just got enough sample into the tube. And now the surgeon's really mad. And so you call hematology to the lab for help. And, this may look simple now, but, when I first got to Children's Hospital Los Angeles, they didn't have this type of testing, which is called heparin neutralization. And so, that works perfectly well. What is heparin neutralization? Well, for samples that are obtained from a heparinized or formerly heparinized line, the heparin can be, neutralized or deactivated. And there's different things the lab can do, different materials. There are enzymes that literally just digest the heparin. There's also some that have an absorptive compound that absorbs the heparin. So essentially, you can take a sample off a line that is running some heparin in there and send it to the lab and tell the lab, hey, you need to heparin neutralize this one. It'll remove the heparin, and then you can get a sample that is as if it's a venipuncture. And here you get a normal PTT, and the patient had their surgery, and the surgeon was happy with you, and he brought you donuts the next day. So keep in mind that that's an important possibility for you. Now, if a patient is on therapeutic heparin, then you have a problem because, of course, if you neutralize the heparin in the sample, it's going to look like the patient's not on heparin. So this is for lines that are heparinized that are causing you problems in getting what you expect to be a normal PTT, or at least a PTT that you want to assess in the absence of heparin. If a patient's on therapeutic heparin, of course, you're not going to do this because, you'll get a normal PTT as if the patient's not on heparin. So it's only for these lines that are affected. So what are some lessons here? An abnormal PT or PTT can be artifactual. A sample from a line that is heparinized will often produce an artifactual result due to the heparin, regardless of how much discard is drawn. I had this recent situation in the neonatal intensive care unit where they just kept drawing more and more discard, and no matter how much they drew, it didn't really matter. And then you can consult the hematology lab consult hematology or the lab to help you. And for the polycythemic sample, they can give you a special tube. And if you don't have heparin neutralization in your hospital, you should definitely talk to them about getting that. But I suspect many of you in big academic centers already have that. Okay, last bits, fairly briefly, factor levels. So the one-stage clotting assay, which is essentially what's called one-stage, but it's basically a PTT-based assay. And so here's your clotting factors again. The only difference is you're adding factor VIII deficient plasma. So for a factor VIII level, in this particular example, if it was a different factor, you'd add the deficient plasma of the other one. So you're adding to this sample plasma that is deficient in factor VIII and basically isolating out that plasma has all the other coagulation proteins. So it's going to give you a normal PTT other than the lack of factor VIII. So the patient sample must supply the factor VIII. The rest is the same, activator, phospholipid, calcium, you run, and the coagulometer is actually running a PTT. But what was done ahead of time that is done in the background is a calibration curve is made that is calibrated to the PTT versus a factor level. So the lab does this ahead of time. They do dilutions of factor levels using normal plasma and factor VIII deficient or factor deficient plasma. And so, for example, the machine will say that there's 76-second PTT in this example, but really the factor level, although that doesn't seem right, but the factor level will come out as 80%. So they make these calibration curves, and that's how factor levels are done, but they're based in the PTT. So remember everything I said earlier about falsely artifactual PTTs, the same problem is going to happen if you don't fill the tube, if you have polycythemia, if the sample sat around too long, if it's not a good blood draw, where you can get, in this case, the PTT would be falsely elevated in a lot of these examples I gave, which means the factor level will be falsely low. Fibrinogen. So fibrinogen is measured really the same as other factor levels, although we call it the fibrinogen test. But it really it's the only difference is that it's based on the thrombin time. So the thrombin time cuts out everything in the coagulation cascade above thrombin. So it doesn't matter how much factor 12 or 11 or 9 or 7 or none of that matters. You're adding thrombin to convert fibrinogen to fibrin. But again, it's drawn in those same blue top tubes, and all the same troubleshooting issues or artifactual issues are applied here. Again, a calibration curve is made, just like I just showed you, except it's to fibrinogen, and the time to make a fibrin clot is the fibrinogen level. So when you get a fibrinogen level in your hospital, it's going to be fibrinogen activity. That is the functional fibrinogen, because you're making a clot here. Lastly, and briefly, the fibrin degradation products, fibrin split products, and D-dimer. What is this all about? So let me just show you the differences between the two. Fibrin degradation products are formed by the breakdown of fibrinogen, so the whole fibrinogen molecule before it actually makes a clot. That's called fibrinogenolysis. And also the breakdown of fibrin clots. You're not separating. The D-dimer is formed by the enzymatic degradation of cross-linked fibrin clots. So you have to have made a full fibrin clot, including with factor 13. And then it's cut by plasmin, and that's what the D-dimer is. So the FDP doesn't distinguish from fibrinolysis and fibrinogenolysis and fibrinolysis. And there are some liver conditions where you can have breakdown of fibrinogen. So the D-dimer is a little bit more sensitive. The D-dimer, it is one of the fibrin degradation products, but it's only formed if the clot is both cross-linked by factor 13 and then lysed by plasmin. FDP can be abnormal in primary fibrinogenolysis, which can happen in liver disease and cancer. We've had actually a few cancer patients in our hospital recently that had this situation, and they were bleeding because they lost their fibrinogen. And also fibrinolysis, which is DIC, or having a DVT, that then the clot's being broken down. The D-dimer is really more specific for fibrinolysis. So DIC, and if somebody has a DVT, they typically are going to have a high D-dimer, even when you start treating them. So this is kind of what it looks like in a schematic. You see at the top, thrombin cleaves fibrinogen, and then you get these long soluble fibrin polymers. And from here, and when those get broken down, you can get the fibrin degradation product and factor or fibrin split product. Once the next step is factor 13 cross-links the fibrin clots, and then plasmin will dissolve them. And once you get the cross-linking, what happens is that before the cross-linking, you see those double Ds at the top there, they get split up. But once they're cross-linked by factor 13 and then cut, you get these double D fragments, which is the D-dimers. And so that's, if you're asking, what is the D-dimer, where does it come from? That's kind of how that forms. And so that's the key difference, is that this is more specific for DIC and DVT, not for fibrinogenolysis. So when are these elevated? Levels are elevated in arterial and venous thrombosis, DIC, and thrombolytic therapy. I already mentioned the difference between FDP and D-dimer, so I won't repeat that. By the way, just so you know, that patients who have a very large bleed and they form a large hematoma, keep in mind that that's clot also. Yeah, they bled, it's not a thrombosis, but that hematoma, let's say somebody had a huge bleed in their abdomen or something, or an intracranial hemorrhage, that also is clotted blood. And as that gets broken down and brought into the circulation to get discarded, that can lead, you will see also a high D-dimer, and if you do an FDP, you'll see a high FDP. That's clotted blood. So that, so keep in mind that a large bleed can give you that. This is not totally specific for a venous thrombosis situation. I'll stop there. I'm originally from New York, and got to visit my old home, New York City, and where I went to college in Albany. And we'll stop there and pass it back to the moderator, back to Vince. Sorry about the trouble with I have to try to figure out what the problem is, but that's for another day. So thank you. I'll stop sharing, and we'll take questions, I guess, later on.
Guy, thank you very much. I think that's a very practical presentation, and you've pointed out a lot of the stuff that we don't typically think about in the ICU. Before I introduce the next speaker, just remember, continue typing in your questions. We're going to go over them at the end of all the presentations. Our next speaker is a professor of pediatrics in this Division of Pediatric Critical Care Medicine at the Medical College of Wisconsin Children's Hospital of Wisconsin. She's also the associate director of their pediatric ICU. And in her prior life, she held several US patents on cardiopulmonary bypass balloon catheters. So the next speaker is Sheila Hansen.
Hello. Thank you, bringing back the far past with the engineering life that I had. I'm going to jump right into this, and we'll be talking about testing that's associated with measuring pharmacologic anticoagulation. There we go. I'm going to quickly cover in the time allotted some of the common laboratory tests that we use in the ICU, specifically anti-factor 10A, which will be abbreviated anti-10A, antithrombin levels, AT, activated clotting time, ACT, and thrombin time I'll go through briefly because Guy did just such a great job on that. To start, I'd like to give an overview of a recent case which I think highlights the complexity of monitoring anticoagulation in critically ill children. And thanks to my partner, Rob Niebler, for bringing this one to my attention. So this is a newborn who was found to have pulmonary atresia with intact ventricular septum with sinusoidal dependency, being evaluated for heart transplant. On day of life 11, he underwent PA banding for significant pulmonary overcirculation, had a cardiac arrest, and was cannulated onto ECMO. So initially, he received his heparin bolus and had a super therapeutic anti-10A level, which then over the next few hours rapidly dropped to an undetectable level. The unfractionated heparin drip was escalated from 28 to 35 to 40, and the anti-10A level was still subtherapeutic. So an antithrombin or AT level was drawn, and it was low, 22%, and so it was replaced with a bolus, and then an infusion started. So with the replacement, the AT level normalized into the 70s, and at that time, the anti-10A level also improved to become therapeutic on the same unfractionated heparin dose. Now then there were some issues with line access, and so the continuous antithrombin infusion was changed to Q12-hour bolus. And with that, there were stable AT and anti-10A levels for the next 3 days or so. On ECMO day 4, the patient was noted, the bilirubin had increased to 11, and then up to the mid-20s. And during this, the anti-10A level on the kind of stable dosing of heparin decreased to 0.26, which is subtherapeutic, and the one after that was unable to be determined. So the team then realized that the bilirubin was interfering with the chromogenic assay. Now there is a clot-based assay of anti-10A, but at our hospital, this is a send out. You'll get the results back a few days later, and so that's not very clinically useful. So it was decided to follow ACT levels, and they looked back and saw that when the heparin level was appropriate by anti-10A, the ACT at that time was 250 to 290. Realizing the limitations of using the ACT as a monitor of heparin anticoagulation, they had to do something, and so titrated the ACT to keep it above 220. So this is a pretty complicated case with a lot of adjustments to patient care. Hopefully by the end of the talk, this will be more clear, and I'll come back to the case then and see what you think. Okay, so the first test we're going to discuss is the anti-factor 10A, which is the same as anti-activated factor 10. And this is a common assay for monitoring anticoagulation. And I think the name can be confusing. The assay does not measure the amount of activated factor 10 or factor 10A, but rather the ability of the patient's plasma to inhibit exogenous factor 10A. So if you recall the cartoon that Michelle introduced of the classic coagulation pathway, factor 10, right here, is inhibited by unfractionated heparin and by low molecular weight heparin. Unfractionated heparin also has some activity at factor 2 or prothrombin, while the low molecular heparin is predominantly the factor 10. And this inhibition of factor 10A is the anticoagulant effect of endogenous antithrombin. So you have antithrombin in the blood, but when it's complexed with unfractionated heparin or low molecular weight heparin, its activity to inhibit 10A is ramped up 1,000-fold, and it inhibits the factor 10A. So by measuring the degree of this factor 10A inhibition, the amount of anticoagulation can be calculated. And it's used one of those curves that Guy went through compared to the standardized lab results. The assay is calibrated differently for each anticoagulant it's measuring. So at our institution, we have a number of different names for the tests. So heparin level, low molecular weight heparin level, enoxaparin level, as well as anti-10A assay. And this assay is the primary assay, I would say, for monitoring low molecular weight heparins, and it's becoming more common for routine monitoring of unfractionated heparin, particularly when factors that affect the PTT, like we talked about, the clotting factor deficiencies or lupus anticoagulant, are present. So there are two flavors to the anti-10A assay, the chromogenic assay and the clotting-based assay. The clotting method was developed first, but it's very labor intensive because it requires sets of serial dilutions to ensure accuracy. And at least at our hospital, it's a send out. The chromogenic assay is the most common used for monitoring the heparinoids and some direct oral anticoagulants or DOACs. I'm going to go through this cartoon in some detail because the other assays are very similar, and I think if you have this down, the others will make sense as well. So first, the patient's plasma is incubated with a known amount of added 10A. The patient's plasma has heparin or whatever anticoagulant, the DOAC or low molecular weight heparin, this is these little green dots, as well as their native antithrombin, which is in the blue here. We add the 10A. Some of it will complex to the heparin antithrombin complex and inhibit the 10A. So when it's inhibited, I have it turned yellow. Then a chromogenic substrate is added, which is illustrated by these little stars. The uninhibited 10A has ability to cleave off a chromophore, and when it does that, it produces some yellow color. The amount of yellow color reflects the amount of residual or uninhibited 10A. And then that amount of color is measured by a spectrophotometer, and using calibration curves, the amount of residual 10A is measured. So the more color, the more residual 10A, the less inhibited 10A, the less anticoagulation. And then that gets reported back as a level, an anti-10A level or a level of inhibition. But it's really measuring the residual 10A and then kind of working backwards. Standard curves are created for each anticoagulant and has an expected inhibition for a given level of that. DOACs that inhibit 10A, so apixaban, edoxaban, rivaroxaban, fondaparinux, they're measured by a very similar type of assay. Some assays may add exogenous antithrombin as well, and this can be called a two-stage assay. Adding the antithrombin in excess will focus the measurement of inhibiting anti-10A to purely the heparin low molecular weight effect. However, most clinicians prefer the single stage where you just add the 10A to represent the in vivo amount of the patient's heparin and antithrombin. The clotting-based assays perform the same way as the first two test tubes, but then instead of adding a chromogenic substrate, a PTT-based factor 10 assay, just like that was described with the factor deficiencies in the previous talk, is done and compared to the curves of clotting time for the known serial dilutions. So What are the limitations? As mentioned, you need a standard curve for each one. You can't compare the Lovenox inhibition to the curve for the unfractionated heparin. And if you have mixed anticoagulants, it would be very confusing. Also, because the spectrometer is measuring a color output, patient factors that affect the clarity or the color of plasma will result in a false assay level. So this includes free hemoglobin from perhaps hemolysis, elevated bilirubin, or lipids. And vendors have varying maximum acceptable levels. So I put here some that I found on the internet, but usually if there's greater than 2 free hemoglobin, you can't count the anti-10 assay as accurate. So anything that's going to produce more color is going to act like there's more residual 10A and less anticoagulation. In addition, antithrombin deficiency, we said that was the complex, right, with the heparin binds to the anti-10A. If AT is deficient, it's going to decrease the amount of factor 10A that's inhibited and result in an underestimation of the heparin level. Also, you need to process the blood samples within about 3 hours because clotting factors can degrade. Overestimate of the heparin low molecular weight level really refers to the filling like talked about in Guy's talk. So underfilling, you're going to have less clotting factors in that plasma. It's going to prolong the clotting time, and it's going to overestimate the anticoagulant effect. Same thing with polycythemia or heparin contamination. So monitoring with an anti-10A assay, the goal therapy really ranges based on which anticoagulant you're using, the dose and frequency, as well as the indication. Enoxaparin requires less frequent monitoring. For treatment dosing, it's typically 1.5 mg per kg BID for patients less than 2 months, 1 per kilo BID for patients over 2 months of age. And there's some limited evidence that critically ill infants on vasopressor support may need increased dosing, about 1.3 mg per kg Q12 in that 2 to 12 month age range. Low molecular weight heparin, the anti-10A level is ordered as a peak. So this is usually 3 to 4 hours after the 3rd or 4th dose. You may have a need to check random or trough levels, particularly in renal failure, to make sure that you're not accumulating. But usually, standardly, it's a peak is what the level is. Heparin contamination through the sample, we talked about both the CVC or the ART line will result in a falsely elevated low molecular weight anti-10A level. So you're trying to measure how much is my low molecular weight inhibiting factor 10, but at the same time when you have the heparin contamination, that's also going to inhibit factor 10, and the assay isn't going to know the difference. So the cure is repeat with a peripheral draw. We also have, if we're going to do frequent monitoring, we will take out any heparin infusion from our arterial line, and we haven't really had much trouble with clotting. All right, here's another case. This is a 3-year-old who's TPN dependent, who with short gut, came in with septic shock. She's on home treatment dose Lovenox for a CVC associated clot. She's on therapy week 3 out of 12. So the team checks a low molecular weight level. The previous levels have been pretty stable, 0.75 to 0.82. And today we get a 1.3. So what's going on? Did we draw it at the wrong time? Sometimes we don't want to go into the line too often, so nursing will try to bundle the labs. Fortunately, this is one that needs to be timed. But remember, we're drawing a peak. So if we draw at anything but the peak, the level should be less, and this should result in an underestimation, not a high level of Lovenox. Worsening renal function. Lovenox is renally metabolized, and you can have accumulation and would result in a higher level. However, in this patient, there's been no change in the kidney function. What about hyperbilirubinemia with sepsis? Remember, anything that can cause a change to the color of the plasma is going to be interpreted as the more of the uninhibited factor 10 and the chromogenic assay. but this again would result in a underestimation. What about contamination from unfractionated heparin? This was drawn from an arterial line. Yes, I wasted a lot. Yes, I wasted a lot. We did a peripheral draw after talking with family and nurse into it, and the level had normalized. All right, switching gears, we'll now talk about antithrombin levels, or AT. So antithrombin is a natural anticoagulant. It inhibits factor 2, factor 10, and a lesser extent 11 and 9. Neonates have about 30 to 50% of adult levels. Originally, there were 6 antithrombins, AT1, AT2, AT3. AT3 is by far the most significant, and pretty much now it's just called antithrombin, though in the cardiovascular literature, you'll still see AT3, but they're the same. You can acquire an AT deficiency, sepsis, liver dysfunction, cardiopulmonary bypass, nephrotic syndrome, pregnancy, and asparaginase use. So a lot of these are common in the ICU. And in addition, heparin use can lower antithrombin activity levels up to about 30%. And this is thought that it's caused by clearing those complexes of AT with the heparin and the 10A, and does not represent an increased thrombotic risk. AT supplementation improves heparin insensitivity. So heparin sensitivity is when you have a appropriate or increasing dose of heparin and you're not able to get a therapeutic level. If the antithrombin level is less than 40%, supplementing it will improve this, and so you will become therapeutic by anti-10A on a lower dose. But the clinical utility is controversial, as it hasn't been shown to either improve patient clinical outcomes or prolong circuit life. And then antithrombin also uses functional assays similar to the anti-10A, chromogenic or clot-based. And the chromogenic uses varying substrate, either bovine or human factor 2 or human factor 10A. So this is going to look really familiar because it's a very similar assay to the previous. The patient's plasma gets incubated with heparin, and then excess amount of whatever your lab's activated factor is. So either the bovine or human factor 2 or bovine 10. And I just called it ZZ here to represent whichever activated factor is used. So the complex of the added heparin with the patient's antithrombin will inactivate this ZZ. And so when it's inactivated, it's all complexed and turns and is inactivated. The residual factor activation, again, will then cleave off a chromophore from the chromogenic substrate and turn yellow, and the amount will be measured. So the more color, the more residual factor, the less antithrombin inhibition, and the lower the antithrombin level. And this then gets compared to standard curves. So activated clotting time is a point-of-care lab that measures the anticoagulant effect, typically at high doses. That is for patients on bypass, ECMO, angioplasty, hemodialysis. Though we do use it to measure and titrate unfractionated heparin, the assay is a very non-specific and global measure of overall blood clotting. At high doses of anticoagulation, the standard PTT becomes unclottable, and so the ACT is used. In a non-anticoagulated patient, the ACT is usually about 100 to 120. Bypass requires the highest levels with an ACT about 400 to 600 seconds, and for ECMO, it does vary by center, patient bleeding risk, the circuit, etc., but often is in about the 180 to 260 range. So it's a very simple test. The patient's whole blood, this time, is added to a tube containing a negatively charged surface activator. And this can be C-Lite, kaolin, glass balls, anything that's going to provide that surface of the platelet activation and activation of the coagulation cascade. Some of the devices have 2 channels. One has heparinase, which will assess coagulation, getting rid of the heparin effect, and then one without. If you have an elevated ACT with a normal heparinase ACT, this shows that you're heparinized. If both are elevated, then a coagulopathy is suggested. This test has been around since the 60s, and originally you fill up your test tube with whole blood, put it in a water bath for 60 seconds, take it out and tilt it every 5 seconds until a clot forms. It's pretty similar now, but it's all automated. And again, it's still a point of care test, and so samples cannot be stored. So factors that prolong the ACT is really anything that can be affected other components of coagulation. So including decreased platelet count, decreased platelet function, low fibrinogen, hemodilution, because you'll have less clotting factors, warfarin, or really any anticoagulant, clotting factors deficiency, hypothermia. Aprotein use will prolong the ACT if C-Lite is your activator, but not the other activators. Okay, the last assay is thrombin time, which we covered. I'll cover this kind of quickly because we just talked about it in the previous one in interest of time. But it's the thrombin time is the time to convert fibrinogen to fibrin. So they add excess thrombin to the plasma. And so really it doesn't matter, as Guy said, what's happening north of here. We're going to start right here. We add thrombin and time this. The thrombin time is very, very sensitive to thrombin inhibitors, particularly unfractionated heparin. So it's way too sensitive to monitor unfractionated heparin, and we would use the other assays instead. To me, the most practical use for the ICU is to determine whether you have heparin contamination in, say, your DIC screen or your anti-10A if the thrombin time is elevated. Factors that prolong the thrombin time, really fibrinogen, if you don't have the precursor or not functional precursor. You can get acquired issues with fibrinogen with DIC, after fibrinolysis, liver disease, cancer. And typically the thrombin time will be prolonged if your fibrinogen is less than 100. Thrombin inhibitors, as the name describes, will inhibit thrombin and prolong your thrombin time, particularly unfractionated heparin. The direct thrombin inhibitors, such as lepirudin, bivalirudin, argatroban, similarly prolong the thrombin time, and again, it's too sensitive to use for monitoring with the standard thrombin time test. But it is useful. A normal thrombin time rules out the presence of these DTIs or heparin. There are some specialty dilute thrombin inhibitor assays that require serial dilution that can be used to measure DTI activity. So we talked about low molecular heparin is mostly anti-10A inhibitor with very minimal activity at factor 2, but in extreme overdoses, you may see a prolongation of thrombin time. The apixaban and rivaroxaban, the DOACs, are pure 10A inhibitors and do not prolong the thrombin time. All right, so going back to our case, some of this may make more sense. So the patient was cannulated onto ECMO. Anticoagulation is needed for the circuit, so they got their heparin bolus and infusion. They were super therapeutic after the bolus, but then instead of falling to a therapeutic level, they went to subtherapeutic. We had evidence of heparin insensitivity because we couldn't get an increase in our anti-10A level despite increasing the dose. So an antithrombin level was checked, it was low and replaced. And then life was good until the patient changed. Remember, the chromogenic assay is going to be invalid if there's any significant changes in the plasma color or clarity. In this case, it was the bilirubin. Unable to do a clot-based assay, and some of the tags or other assays may be appropriate, as we'll talk about in the next talk. But the decision was made to titrate off of the ACT, knowing that the ACT would be affected by platelets, fibrinogen, all of the other contributions to anticoagulation. So kind of used it as a placeholder. So covered a lot rather quickly. So please put your questions in the question box and we'll talk soon.
Sheila, thank you very much. It's a very good lecture. As Sheila mentioned, for those who just joined us, please enter your questions into the chat box. After the next lecture, we'll have more than enough time to answer all of them. So to introduce our next presenter, she's a professor of pediatrics in the Division of Pediatric Hematology Oncology at Central Michigan University Children's Hospital of Michigan. She's also the director of the Hemophilia Treatment Center and the Hemostasis Program at Children's Hospital of Michigan. She headed the International Society of Thrombosis and Hemostasis, a standardization committee on viscoelastic testing. So to give us a talk on this topic that's pretty close to her heart, we have Mira Chitler.
Hello, everyone. Good afternoon. Sorry, I am just trying to get my screen to work well. Can you guys see my screen?
Yes.
You can see my screen. I can't see it myself. Give me a second. I'm sorry.
Mira, I wonder to what extent you have it on a second screen, because
I actually have it on a second screen, and it would fine just a couple.
We only see your second screen probably.
Yeah, you're probably seeing my second screen. Give me 1 second. I'm sorry. Not working. Okay. All right. I'm just going to work with what I have. You are seeing my second screen, and it's right. It's not the presenter mode you're seeing, right?
No, we're just seeing, yeah, it's on the slideshow.
Okay. All right. So thank you, everyone. And thank you for the invitation for this afternoon. And it's my pleasure to talk to you today about viscoelastic testing.
Mira, so right now you are on the PowerPoint, the production screen. There you go. Perfect.
Sorry, thank you. So, all right. Sorry, guys. So it's my pleasure to talk to you this afternoon about viscoelastic testing. This is a new age. I guess we all have to grow up and become technically more competent, including especially myself. So here I am. I am going to try to do this as quickly as I can so I can give you all opportunities to ask questions. These are my disclosures, none of which are relevant to my talks. My objectives are to talk to you today about how viscoelastic testing is performed, how the different parameters relate to the coagulation system, and how to interpret these results. And I'll try to give you some examples if we have time. Otherwise, we may just skip on those. So we just got an excellent overview of hemostasis and all the different tests that we use in our labs to assess coagulation. And we can see now that the tests that were designed, these tests were really designed to individually test the different steps in the hemostatic process. However, if there are issues in more than one step in this process, we really don't have a good way to assess the combined impact on hemostasis. So an ideal hemostasis assay should actually measure all of these processes at relevant shear conditions and provide results in a timely manner. So that's what we all aim for one day. But right now, we're not there yet, but hopefully we'll get there soon. So with improvement in technology, we've actually embarked on more invasive management approaches for our patients. And unfortunately, this sometimes causes significant disruption of normal physiology. If you think about ECMO, bypass, resuscitation, advances in therapeutics, especially all the new hemophilia drugs that we have now, they involve interventions that alter hemostasis in a way that requires that we be able to assess hemostasis from a more global perspective. So this, I think, has resulted in more attention now being directed towards understanding the technology of global hemostasis assays to help harness this, the utility of these tests. So the main global assays we have right now that have the most data are really the viscoelastic assays, which include the TEG and the ROTEM, the thrombin generation assays, and the clot waveform analysis. So today we'll talk about viscoelastic assays. So what do they really measure? The viscosity of blood actually changes as the fibrin network forms, as coagulation takes place. So these assays essentially enable us to therefore look at clot formation, elasticity, and fibrinolysis actually in real time. So the elasticity of a clot depends on a number of factors, including platelet number, platelet function, hematocrits, fibrinogen, factor 13, thrombin generation. So all of these actually play a role in how much elasticity the clot has. So unless we put everything together, we really are not assessing clotting adequately. It is important to remember that the major signal in these assays actually comes from the platelet contractile forces, and some of it comes from the fibrin network. I would also like to stress very clearly that this is a screening test. It can tell you where something might be wrong and where we need to look, but it cannot give you a diagnosis of a specific defect. So the primary drawback of these assays has been intra and intra-laboratory variability, but I think with improvement in technology, this may no longer be an issue. So this technology has really changed over time. The 1948 picture that you're seeing here was the one Dr. Hartett first designed or invented as a thromboelastograph in an attempt to try to measure a PTT in the battlefield during World War II. Unfortunately, this was a huge machine that required a film to record the tracing of the clot, and so it never was really used. So in 1999, with more improvements in liver transplant technology, the TEG actually came to be of use. And this is the instrument, the TEG 5000, that is mostly used nowadays. But as of the last 6 months, we now have the TEG 6S, which really is much smaller than the toaster-sized TEG 5000 that we used to have, and is technologically much more rapid and more point of care. So thanks to Dr. Young for this slide. So this actually highlights to us how small things are now compared to the table-sized thromboelastograph that was initially invented. So this instrument is based on a cup and pin technology. So there is a pin that you can see there, and the cup actually sits in the depression that is there. So this is the cover for the pin that is put up there, and the cup actually sits in this spot here where the sample can be loaded. So once the sample is loaded into the cup, it is then pushed up against the pin that's on the top, and you just press the button that says go. So what happens then is that the blood that is inside the cup, the pin and the cup actually oscillate, and they oscillate independently of each other. When the blood is liquid, there is nothing that prevents or connects the pin to the cup, and therefore they are allowed to rotate independently of each other. But as fibrin strands form and connect the wall of the cup to this pin, then the two of them are forced to move in unison. And so this change in viscosity that forces this cup and pin to move together then results in changes that are picked up by this torsion wire and the curve that we are very familiar with in terms of the TEG tracing. So today we have the TEG6S, which also measures changes in viscoelasticity, but uses resonant frequency technology. And it's actually a multi-channel cartridge that allows 4 assays to be performed simultaneously. An LED detector measures the up and down motion of the blood meniscus, and the frequency leading to resonance change is identified, and that leads to the readout. So a stronger clot is supposed to have a higher resonant frequency and higher TEG readouts. So small unmetered amounts of blood are actually loaded into the cartridge. It's a citrated sample or a heparinized sample that needs to be loaded here. And the readout is pretty rapid. So because there's less of pipetting errors that can be introduced into the system, there's less chances of variability. 4 tracings are generated here, and they're superimposed and then need to be interpreted. So most of us are still working with the TEG 5000, including myself as of now. And so many things that I'm going to be talking to you today about are referring to the TEG 5000. I don't know that there's that much data as the TEG 5000 on the TEG6S. There is quite a bit, but today, most of the discussions will be on the TEG 5000. So this slide essentially shows you the differences between the TEG 5000 and the ROTEM. They are both viscoelastic assays, and one is thromboelastography and the other one is thromboelastometry. The differences here are pointed out. Primarily, the ROTEM is much more automated than the TEG is. And in the ROTEM, the cup is fixed, whereas in the TEG, the cup is moving. They both actually can have temperature alterations that can be made. So you can actually study the process of coagulation in a more physiologic temperature, but you can also, with more technology and cooling protocols taking place now, if you wanted to study coagulation in a baby that's undergoing cooling, you can actually bring down the temperature of your TEG or the ROTEM to the temperature that the baby's at and study coagulation at that temperature. The cup materials are also slightly different between the two, but the readouts are really the same and the interpretations are very similar. So the global assays can be done without the use of any activators, but that means the results are more delayed. And in some situations, that's not very practical. And so several activators have been utilized to stimulate activations, just like we do in our PT and PTT assays. So this is a list of all the assays on the ROTEM. The INTEM refers to contact activation, XTEM to tissue factor or extrinsic pathway, which would be similar to PT. The HEPTEM is a heparinase assay, and in combination with the XTEM can be used to assess heparin effect. APTEM is an assay that has a proteinin to inhibit fibrinolysis, and again in combination with the XTEM can be used to assess fibrinolysis. FibTEM is a measure of fibrinogen activity, where they use an actin polymerization inhibitor to block platelets so that the clot formation is directly driven by fibrinogen. NATEM refers to the one where there's no activator added and just recalcification takes place. So next, we'll look at the assays on the TEG, which are very similar to what I just said for the ROTEM. The activators that are used are slightly different. In addition to the assays, traditional assays that I just referred to on the ROTEM, there's also a platelet mapping assay on the TEG, where a heparinized sample of blood is used along with activators to look at specifically inhibition of the ADP and the arachidonic acid receptors on the platelet in response to in response to the agonist specifically, without using thrombin here. And the TEG success I just talked about, so I won't go over it again. So let's talk about, this is the curve. And so let's talk about the different phases of coagulation on this curve and try to better understand what happens here. So when blood is placed in the cup and the instrument is started, the pin and the cup are oscillating independently of each other. And so essentially you get a straight line, which is the R time. Okay. Once fibrin strands are generated and the pin and the cup are forced to move in unison, then you find that this curve is generated. And essentially the time that it takes to make a curve that is 2 millimeters long is referred to as the K time. So continued propagation of the clot is reflected by widening of this curve, and as platelets and fibrinogen get engaged in this process. The platelet contractile forces and fibrinogen activity primarily contribute to the maximum clot strength, and therefore activated platelets in high numbers or high fibrinogen activities will result in higher MAs and a stronger clot. Any exaggeration of fibrinolysis will result in a decrease in clot strength, which will be reflected by these two lines coming back to a straight line or partially coming down, resulting in a drop in maximum amplitude. So if we had to look at this and try to correlate it with the standard coagulation assays that we have. So in this picture I have on the top here, which is the cell-based clotting coagulation cartoon that we had before, where you have initiation, amplification, and propagation. And in the bottom, we have the TEG curve. Okay, so if you had to look at how this would correlate, you can see that the R time specifically is looking at the enzymatic phases of coagulation, which means all the clotting factor based initiation of coagulation is what your R time is reflecting. So then when you come to the K and the angle, this is the time where von Willebrand factor and platelets and fibrinogen are recruited into this equation. And therefore, now you're looking at function of these components as well. And in the last step, which is primarily the propagation of the clot, it is primarily driven here by platelets and fibrinogen. So you can sort of look and try to see what the correlation between all of these would be, okay? So here's the TEG success curve. And like I said, there are 3 or 4 curves that are generated and they're all superimposed one on the other. And this essentially looks at how much time it takes for each of these tests to get a readout. And on the rapid TEG, you can assess the reaction time or the enzymatic phase of coagulation within about 10 minutes. And if you're looking for lysis, you probably would have to wait about 30 or 40 minutes. And so, which I think is still much faster than sending something out to the laboratory. So it's still a pretty fast test. And the fact that you can see the curve in front of you and sort of try to get a better picture of coagulation is really what I find most interesting and fascinating about this test. So these are all the patterns that you would see in based on what kind of abnormalities you have in your coagulation system. So there are some hemorrhagic patterns, thrombotic patterns, and fibrinolytic patterns that we're going to look at here. So if you have low clotting factor function, essentially your R time is going to be long. Whereas if you have low platelet function, your MA is going to be low. If your fibrinogen is a problem, then you're going to see a problem with clot propagation in the middle there, okay? The amplification is going to be a little bit off. And so you're going to see problems primarily with prolongation of the R time because it's still, initiation also may be delayed. And then the time it takes for that K or 2 millimeters of clot going to be formed is going to be prolonged. So fibrinogen defects would be picked up that way. If you have low clotting factors and low platelet function, you will have a long R time, a long K time, and a low MA. On the other hand, if you have a thrombotic problem, if your platelets are either too many in number or excessively sticky, then you may see platelet hypercoagulability, which would be reflected in terms of having a very wide MA. If it's an enzymatic hypercoagulability, which means you have a really high factor 8 or a really high factor 9 or something of that nature, which makes your PTT really, really short, then what you're going to see is this next one, where the R time is really, really short, but the rest of it is within normal limits. If you have both enzymatic and platelet hypercoagulability, which means you have high clotting factors as well as platelet hypercoagulability and a high fibrinogen level, you may see a short R time as well as a very wide MA. Then coming to the fibrinolytic issues, if you have primary hyperfibrinolysis, you will see this rapid clot formation that goes down really, really rapidly. On the other hand, if it's secondary fibrinolysis, you will get a good clot formation, but then gradually over time, you will see that it comes down more quickly than you would have anticipated otherwise. So this I found it recently, but I see that a lot of intensivists apparently use this. I didn't even know that. So there are some common TEG patterns that have been correlated with wine glass shapes. So if it looks like a brandy snifter, it is supposed to be a normal curve. If it looks like a red wine glass, because your R time is long and your K may be prolonged, you have a red wine glass type curve. On the other hand, if it's like a champagne flute, your MA is low, plus you have a long R time and a long K time, so you might require some fibrinogen there. And if it looks like a test tube, your platelets are primarily affected, and if it looks like an inverted martini glass, then you're lysing really quickly. I thought that was very interesting, and I'm sure you guys probably know it, use it more than I do. Going back to that, this was just the ROTEM, similar curves, similar results. And for lack of time, I won't repeat it again. Okay, so this picture actually tells you how similar the two are. There is slight difference in terminology, but what they're trying to tell you is exactly the same. So where do we use this now? Okay, so the TEG at this point of time is only licensed to be used for providing transfusion guidance. Okay, although I think this test has much more utility than providing transfusion guidance. That's the only FDA approved utility for this test at this point of time. So as you can see here, this is what the recommendations are based on what the curve might be. If you have a really long R time, then because you're missing enzymatic factors of coagulation, you might consider giving FFP or a prothrombin complex concentrate. If the K or the angle is low, then you might want to consider giving fibrinogen. And if the MA is low, then you want to give platelets. On the other hand, if clot breaks down very quickly, then you might want to consider an antifibrinolytic. I don't think it's this black and white, to tell you the truth. I really feel you have to pay attention to every component of this, and there's quite a bit of overlap between the fibrinogen and the platelet. It's not this black and white, but this is where the recommendations are at this point of time. And several algorithms have been developed, especially in the trauma field, to try to utilize the TEG to decrease the use more judiciously use the factor and blood product concentrates. So coming to the TEG platelet mapping, on the ROTEM, we can separate the platelet component of the MA from the fibrinogen component, as you can see here. So the FibTem and the XTem, so you know that this is a fibrinogen component of this MA, whereas this refers to the platelet component of this MA. You can do the similar thing on the TEG, but on the TEG, we also have the platelet mapping assay, which allows us to determine if there is specific inhibition of the ADP or the arachidonic acid receptor. These assays were primarily designed to assist cardiologists in managing drugs like aspirin and Plavix. So essentially you get three curves. One is a Coagulation curve to look at the thrombin-induced platelet activation. The second is a heparinized sample of blood that is used to inhibit thrombin. And then specifically you add either ADP or arachidonic acid so that you can look at the platelet component of that receptor activation. And then the third curve is the fibrinogen curve that's looking at the component, the fibrinogen component of this maximum amplitude. And technically you would expect, if there is no problem with the receptor ADP or arachidonic acid, that this MA and the MA of thrombin should be very close together. If they are not, there is a possibility that either you're on a drug that inhibits these receptors, which is the reason these tests were designed, or maybe there is a receptor dysfunction that is causing that problem. It's also important to remember that the percentage inhibition should not be viewed singularly as a number. You have to make sure that the patient has normal thrombin-mediated platelet function, and then look at the inhibition. So if you see in the picture, this person has a really wide MA, so 50% inhibition for this person is not the same as 50% inhibition for this patient. So be cautious of that. So utility of these tests, I'm just going to go through some slides really quickly for this, okay? I'd like to start with some scenarios here, and the first one I'm going to talk about is actually something that came out of WashU. So they looked at essentially the incidence of platelet dysfunction in patients who were on ECMO, and they tried to, it was a retrospective study. They went back and looked at 24 patients who had had 57 samples of blood that had been sent for platelet mapping. The unfractionated heparin dose was at 40 units per kilo per hour, a median for all of these patients. They did find that there was platelet dysfunction on ECMO, which was greater than what they would have expected on cardiopulmonary bypass. But I think the more important thing was that the absolute platelet count and the TG platelet mapping had a significant predictive value on severity of bleeding as well as mortality of these patients who are on ECMO. So I think there's a lot of utility to these tests, and we just need to explore more and look more at these. When we have more than one problem, like I talked to you before, it's very difficult to find a test that can do anything, that can explain what the impact of having two problems is on your process of coagulation. So this actually is a patient that we have with factor 13 deficiency and type 2A1 Willebrand's disease. And we have a lysis assay that's been set up where we add TPA to the specimen to exaggerate the lysis. And here's a normal person. Here's a person who has just factor 13 deficiency, and here's our person. So you can see that it truly impacts the fact that he cannot make a clot very easily because of the type 2A1 Willebrand's disease, and the fact that he can lyse very quickly because of the lack of factor 13 truly impacts his ability to make a blood clot. Similarly, fibrinogen issues can be assessed using these new assays. This was a patient that we were able to name a new fibrinogen, a mutation based on the studies that we did for this patient to diagnose her with dysfibrinogenemia. Just FYI, the very first dysfibrinogen or dysfibrinogenemia or fibrinogen mutation was actually first detected in Detroit, and so it was named Fibrinogen Detroit. To maintain that continuity, we called ours Fibrinogen Detroit 2. So again, coming back to ECMO. So this is a baby with factor 12 deficiency and meconium aspiration who was on ECMO. So you can see that because this is a kaolin activated study, the factor 12 deficiency results in a very long R time. And this baby had thrombocytopenia resulting in a very low MA. The APTT was greater than 150 seconds, even though this anti-10A was appropriate at 0.5. So here you have to remember, you have to look at all the assays and try to understand why do they not match up. And when we measured based on the fact that this really long R time and the PTT being as long as it was, we actually measured the factor 12 activity and it was 25%. And FYI, this patient never clotted, which is something that we know might happen if you have a 12 deficiency. Here again is the effect of antithrombin and heparin together. This is the same patient. Here, the patient at 27 units per kilo per hour with antithrombin of 23%. You can see that the R time is appropriately prolonged and the clot formation is appropriate. Once the the inappropriately not prolonged enough, and it looks like the clot formation is much more amplified, whereas once the 83 was appropriately substituted and brought to just above 50%, you can see that the R time became appropriately prolonged. And so the effect of adding antithrombin to the heparin was very nicely demonstrated here. Okay, so I am going to really not go through all of these slides in detail because we're already running out of time and I want you to have time for questions. So this is the death diamond. What they found was that patients who have significant hyperfibrinolysis in trauma had much more higher mortality rates than compared to patients who did not have significant hyperfibrinolysis. On the other hand, if you don't have any fibrinolysis, these were also situations that were associated with a higher incidence of DVT and also mortality in patients who had trauma. Again, platelet dysfunction was noted to be significantly associated with increased mortality in traumatic brain injury patients. The more the dysfunction, the more your odds ratio of having higher mortality and morbidity. You can't stop any talk now without COVID-19. So I wanted to put up one slide here that shows that the TEG in this study from Italy was able to demonstrate hypercoagulability on TEG in patients who had COVID. Okay, high K, high angle, high MA. So at our center, we're also doing another study to look at ECMO and thrombin generation and thromboelastography and thrombin generation. This is my colleague, Dr. Kate Regling, who's doing the study with me. We've actually enrolled almost 28 patients so far. We just got another call for another patient to go on. We've had some interesting results. We were able to show that the amount of thrombin generated as assessed by TEG was significantly lower in patients who bled. We were also able to show that microparticles in patients who had thrombosis were higher. So I just want to end by saying this was a nice paper by Dr. Levy and Beverly Hunt, where they looked at the use of point of care TEG in situations like cardiopulmonary bypass, trauma, and hypercoagulable states. And their conclusion was that you can't recommend one test for the evaluation of coagulation status, and you need a combination of tests in these situations. But the point of care TEG has a role in providing the hematologist with better insight on hemostasis compared to coagulation, other standard coagulation tests. Thank you very much, and I'm open to questions.
Mira, thank you very much. I think Mira mentioned a very important concept, right? I mean, we see like not all tests correlate, and the important thing is trying to understand the underlying pathophysiology, and that was one of the reasons why we came up with this webinar. So thank you very much, Mira. Can I request Sheila to turn your video on? So to moderate the Q&A, we have Phil Spinella, who we all know. He was the founding chair of BloodNet, and he's a professor of pediatrics at WashU. Phil.
Great, thank you, Vince. So we have about 14 minutes. I want to ask Guy, Sheila, and Mira, if you can, try to keep your answers as short as possible so we can get to as many questions as we can. Each of you did a really great job at explaining how the tests were done and what they mean, but we really didn't get into comparing the utility of one assay or the other for either directing anticoagulation or for directing blood products in patients that are bleeding. I think the biggest controversy in this area is how to best direct anticoagulation for patients. So I want to start there. And I want to ask each of you, if for your patients where you're titrating heparin infusions for anticoagulation, which assay do you primarily use to direct anticoagulation? I agree with Mira's last point, and we do the same thing. We actually measure all of them and try to look at them in aggregate and come up with an approach, but you still need to have a primary assay that you wind up often titrating your medications on, especially when you have a whole group of people that you're trying to get to follow a certain approach. So Guy, I'll start with you. For heparin infusion anticoagulation titration, what assay do you use and why?
So we use the anti-10A assay pretty much exclusively for that. Why? It's because it takes out a lot of the variability associated with the other assays. So in particular, I'll just give one brief example so I can keep my answer brief regarding the PTT. A lot of things that are not pre-analytic, I talk about the pre-analytic things in my talk, but there's analytic things that you can't control, or things in the patient sample that can't be controlled. So let me give you this example. A lot of patients in the ICU have infection, inflammation, stress, and factor VIII is an acute phase reactant. So it can go up to levels of 200, 300%, which is enough to actually then, lower the PT. That much factor VIII can make your PTT lower within the normal range, right? So you're not going to see a short PTT, but instead of that patient's PTT, say, being 35 seconds, if the upper limit of normal is 37, it might be 26 seconds if the lower limit of normal is 24. Well, now you're going to, try to measure the effect of heparin. Well, if that patient's factor VIII is 300% because they're inflamed that week, you're going to get a artificially lower PTT, and it's going to look like the patient's not anticoagulated. In fact, I saw one of the questions about the disassociation between the anti-10A and PTT. So that could be one reason why, and probably a common reason why the PTT could be artificially shortened. The factor 10A assay takes all of that away and really just focuses on the 10A. So I think too many things affect the PTT, and that's why we use the 10A assay.
Gotcha, great. Sheila?
I think it depends on the situation. We do fall back on the anti-10A. We don't use the PTT much for heparin titration. I think TAG comes into play as well if there's other, if the child is on ECMO, has issues with platelets or very septic, where you think that they're, a perfectly healthy kid, which why they're on an unfractionated heparin is probably rare in the ICU, but sometimes. Then I think the 10A is probably sufficient. So what realistically, it's still a little bit more harder for us to get TAG. Our process is getting quicker and better. Because the 10A is just measuring the amount of inhibition of that factor, it doesn't say how much factor that patient has in vivo and how much you're inhibiting their in vivo factor 10. That sometimes get a little bit more of a global picture on both the R time, the platelet effect, and the other things. I think the TAG can be a complementary help.
Gotcha, great. Mira?
Yeah, so I agree with both my co-speakers, and we use the 10A to anti-10A2 primarily for heparin, unless, of course, if the patient is on ECMO, we actually use a combination of tests that includes TAG. But because our TAG is not available around the clock, that's the other thing. So we have to rely more on the anti-10A, which can be available at any given time possible. So if it's heparin titration, we primarily go with the anti-10A. But if it involves bypass or ECMO, then we will use a combination of tests.
If I can just add a brief comment, which is because I see a question from Haley Christian there about a prolonged PTT. So what I said earlier is that there are things in the plasma that can shorten the PTT and therefore give you a situation where it doesn't look like you have enough heparin in the blood. And the corollary is true too. you can have situations where certain factor levels may be depleted, and that will give you a elevated PTT because the factor level is lower, and then it looks like you have too much heparin. So what I said earlier about the lowering and it works both ways.
Got you. Great. So it's interesting. It sounds like at least Sheila and Mira would use TEG more often to titrate heparin, but the availability makes it harder for you to use.
And Phil, I think also the experience is coming, so it's the availability. The more you use it, the more you use it, the more helpful it is. So I think it is kind of a technology that is finding really the great niche that we need.
Right. Just my quick comment, and then we'll move on. As you inferred, Sheila, the anti-10A is really only telling you the amount of inhibition that's occurring at 10A. And our patients start with different thrombin and fibrinogen function when we start anticoagulation. So if patients are incredibly prothrombotic, like some of these COVID patients, an anti-10A of 0.5 may still leave them hypercoagulable and still at risk of thrombotic complications, where if a patient who doesn't have COVID but just needs to be on anticoagulation for another reason, an inhibition of 0.5 may bring them down to a hypocoagulable state. So it's like when we have patients on epinephrine, right? We don't get an epinephrine level and titrate that to improve their cardiac output. We measure cardiac output. So at least from my perspective, with TEG, with the R time is telling you the time to initial fibrin formation, which is giving you an overall sense of their hemostatic function versus just a drug level. But I'll let that go because I didn't speak. I'm just a question asking guy. Let's move on to bleeding. So for patients with significant bleeding, I'll almost ask the same question. Not life-threatening massive bleeding, where I think many people are now going towards empiric transfusion without getting labs to indicate blood products. But what assays do you use in bleeding patients to indicate platelet and plasma and cryoprecipitate transfusions? Well, let's go backwards now. Mira, you get to go first.
Okay. So I think we do use, in bleeding patients, we do use a combination of tests. We do measure the fibrinogen. You will measure the PT-PTT. We will also get a TEG to see if we can understand what this combination of lack of factors or platelets is doing to the whole coagulation system. I think when a patient is bleeding, it becomes quite complicated in that you have to make sure you understand the whole scenario and the underlying clinical condition that's causing all this bleeding issue. So a combination of tests is what I would prefer to use rather than one test.
Okay, Sheila?
The same, though TEG we use a lot more with our bleeding patients than as for monitoring unfractionated heparin. So even if not massive bleeding, we do follow fibrinogen for cryoprecipitate. However, if the TEG also, despite having a fibrinogen level above 100, if the TEG showed some deficiency, then we would replace. So we use a combination, but I think then the TEG is stronger.
Guy?
Yeah, I would just say briefly, you have to ask yourself, why is the patient bleeding? Is there some deficiency of a clotting protein? And that can happen in the ICU with liver issues and poor nutrition and low vitamin K. So those things need to be thought about. And there are specific treatments for that. Is it hyperfibrinolysis, which we talked about a little bit earlier? So looking at your D-dimer and your fibrin split products, and that's where TEG is particularly useful, I think, because there's no really good test for that. Or is it, is it a suture deficiency, right? What I call a surgical bleed, right? And so I think those are the ways to think about it, and then to apply the tests as appropriate, depending on why you think the patient is bleeding.
Great. Sylvia Barati asked, if you're on a heparin infusion and your PTT is not increasing, it's normal, but you check your antithrombin and it's normal, and your ACT is normal. So escalating doses of heparin, normal PTT and ACT and antithrombin. What does that make you think? And if you know, and I'll just ask Guy this since we're short on time.
Sorry, you said normal PT and PTT?
Well, that wasn't part of the question, but yes, let's presume PTT and PT are normal. ACT is normal, but there's escalating doses of heparin, meaning if you can't get the PTT up, there's heparin resistance, and your ATT is normal. Antithrombin is normal.
Yeah, I mean, there are patients, and it's been reported, who are just particularly resistant to heparin, and they just don't respond no matter what you do. You investigate the hell out of it, and you can't figure out what it is. You're up to 50, 60 units per kilo per hour, and you're not getting anywhere. And, that's often the point where if I'm really stuck and I can't figure it out, and sometimes you can't, I'll switch to another anticoagulant.
Exactly. We have the same practice here, too. Renee Roy asks, how much information does platelet mapping provide for patients on ECMO? And I guess, let's say, presuming they're, well, either I guess the direct anticoagulation, if they're not significantly bleeding or not clotting, just in and of itself, do you use platelet mapping, Mira, for patients on ECMO?
No, I don't, because you know that platelets are going to be eaten and chewed up in that oxygenator. So we've done it on a couple patients, but you expect to see significant inhibition of the platelets. I don't exactly know what it means even. I think more work needs to be done. I know you showed very nicely in your study that inhibition was associated with increased mortality, but hopefully we will get more data of that nature that will help us understand that, but I haven't used it in our ECMO patients to guide therapy.
But our theory was that there's increased nitric oxide production in these patients with hypoperfusion when they're on ECMO, and that, as you know, nitric oxide inhibits ADP, and that either platelet count or even just a non-platelet mapping tag, a regular Kalin, is overrepresenting platelet function. So if that patient bleeds, I know now to give them platelets first, even though their count may be normal, because there's a significant increased inhibition potentially due to nitric oxide, related mechanisms. Any questions the three of you want to ask each other in 1 minute? No? Well, then I'll just stop here and say thank you to the three of you for spending the time to put these lectures together. I think they were great. And, as intensivists, we deal with coagulation all the time, and it's unfortunate that most of us typically are not taught to this degree about how the tests are done and how to best interpret them. So hopefully this will be the beginning of a series of lectures where we can then maybe go into specific topics. I have a very good feeling anticoagulation on ECMO will be the next 2-hour talk. But Michelle or Vince, do you want to close it all?
Thanks, everyone. And just make sure you provide us feedback. As Phil said, this is not the last. We're going to have more webinars, and we definitely want to do better the next time.
People ask me, the recording should be on the BloodNet webpage, and that's going to be Oliver's job. Oliver's agreed to put it on the website. So I'm sure you can find the BloodNet website. Google BloodNet, you'll find it. And the recordings will be there.
Thanks to all our speakers again. Thanks for all your time.
Thanks.
Bye, everyone.
Everybody.
Enjoy the weekend.